Good afternoon. Welcome to Open Classroom. I'm Janet Gillow, the Director of Professional Development for the Brown School here at Washington University in St. Louis. So glad that you chose to be a part of today's program. I want to thank and acknowledge my friend and co-host, Cynthia Williams. She's here to help also moderate the chat, take note of questions that you have throughout the program. For those of you joining us on Zoom, we can't see or hear you. Can't call on raised hand, but chat is enabled. Many of you have already checked in to tell us who you are and where you're coming from, but we welcome you to continue to engage. Let us know comments that you have as you go, questions that you have for Ryan. We will have some time at the end to bring you into this room, and Cynthia and I will be your voice. Before we get started, I want to just let you know what we have coming up. We're hitting a very, very busy time at Open Classroom, which means lots of different things happening, hopefully something that's interesting to nearly everybody. So just briefly what we have going on next week. We're on Monday. We're going to have a program called Advocacy and Allyship, welcoming Afghans to St. Louis, people that are involved in the resettlement efforts for, depending on what you hear, 1,000 or 1,500 Afghans that are moving into our area, and what we can do to support these new neighbors. Then on Tuesday, the 26th of October, Dr. Rosora Orenga Okeyo with University of South Carolina is coming. She's been invited by the Center for Mental Health Services Research here at the Brown School to deliver a program called Partnership and Adaptation to Implement Trauma-Focused Therapy in Low Resource Settings in the US and Latin America. And then on Wednesday of next week, we have the first of two programs that we're doing about the Brown School strategic plan. We have launched a new plan that's going to guide our operations through the year 2030. It includes commitments to the community and science. And if you're a stakeholder in our organization and want to know what we have planned, please do come to engage in that conversation with us. But now I'm going to talk about today's program. Ryan Lindsay is Associate Professor of the Practice here, Chair of our Mental Health concentration. He has spoken to Open Classroom a few times before, and I hate to recycle my intros. So I was trying to think what I'm going to say that I haven't said before. So in Ryan's practice and in his role as an educator and a trainer, he leans into some of the hardest suffering people can contend with. He is brave in spaces where others can't be or don't care to be. And to encourage our students, for the longest time, Ryan had this quote on his door: "You are competent enough to be helpful. You don't have to know it all. You can't fix it all, but you can help." So please join us in that spirit of becoming more competent so that we can be more helpful. Please welcome my dear friend, Ryan Lindsay.
Oh, you make me cry already. Center this. Welcome, everyone. Again, I'm Ryan Lindsay, and I'm so glad that you have taken this afternoon to spend an hour talking about a topic that's very dear to my heart, and that's individuals experiencing suicide. But how do we help engage families in this process, knowing how critical family engagement in the prevention of suicide is? And I just want to kind of center today and thank Open Classrooms, the Brown School, Janet, and everybody for inviting me to just share this information. And I also want to just, I'm sharing a lot of my clinical experience through this. So I'm weaving in ideas and some literature and some facts, but I'm mostly focused on what have I learned throughout the process of working with lots of families who have a young one and a youth who is thinking about suicide, maybe has attempted suicide in the past, or is engaged in non-suicidal self-injury. I am a nationally certified clinician in dialectical behavior therapy, so that is my primary form of treatment, working with youth and adults and families experiencing suicidal behavior. So I just want to kind of put that out there in terms of my lens of what brings that. I'm also native of St. Louis. I grew up here. If anybody came on a little bit earlier, I got to share a lot about my Irish Catholic upbringing with my 21 cousins and my just world kind of growing up here, and how I wasn't that great as a kid, but I grew up to be a much better adult. And so I just want to kind of center a little bit about me. All right, let's see if I can get my tech to work. All right, I also want to just put a plug out there for some amazing colleagues that are on today with me. Listen, McCulloch, I saw you. I don't know if the others from our coalition are on here, but the St. Louis Regional Suicide Prevention Coalition is a group of stakeholders who have come together to really address suicide prevention in our region. And if you're anywhere around this region, or you're part of a closely related region, you wanna partner with us or talk to us, visit our website or email Hannah Schleicher if you're interested in joining the coalition or learning more about that. And later on, I'll put that email in the chat. So I do want to center our conversation about, in the context of what is the state of suicide in our communities. And I think about suicide in terms of suicide prevention and the presence of suicidal behavior, all the way from individuals who have thought about suicide, all the way to, with individuals who make a plan, individuals who attempt suicide, but also those who have lost their lives to suicide. And in the United States, this is a very serious problem that needs addressing and accounts for a lot of lost lives every year. And many families and communities are impacted by losses to suicide. And what I also want to kind of center this around is that, only about half of people who think about suicide are engaged in any kind of mental health services or treatment. And so, we have a very large population of individuals who are thinking about suicide that have never reached out or are unable to access services. And, there's a lot of really good work that is trying to fill that gap, to understand why is there a gap in that context. And what I want to say is that for our youth, although I don't have these stats in this slide, our youth are even less connected to services who are thinking about suicide than our adult populations. And that anybody who's in the role of provider or working with individuals who have a diagnosis of major depressive disorder and some other key mental health conditions, suicide is very much a part of that experience. And so as a mental health provider myself, as a clinical social worker and a clinical social work educator, a large portion of the work that I do is around how we raise competencies around our suicide risk assessment, intervention strategies, but also how do we create systems that are able to identify and link appropriately to effective resources in our community. In Missouri, I want to, we're centered in Missouri, so I want to kind of add some Missouri data. And this is from my very good friends over at the Missouri Institute of Mental Health, who were willing and generous enough to share this information around what does suicide look like in Missouri and how do we compare to other states. And what I want to say, just similarly to other states, is suicide is the second leading cause of death for 10 to 17-year-olds. And a very important part of this conversation is that 60% of all suicide deaths in Missouri are by firearms. And so if we're going to have a conversation around safety planning, we're going to have a conversation around suicide, we also have to have a conversation around safe storage of lethal means, and specifically how do we think about, and how do we engage in a conversation about safely storing and putting space between access to firearms and a person who's experiencing suicidal ideation or planning. Today, we're going to talk about engaging families. So we have some really good data about, the importance of family-based interventions to prevent suicide. And there's more and more data that are coming out that really center the role of families as partners in this process, and the need for families to be actively engaged in our safety planning, but also in our risk assessment process and treatment, so that we can prevent the need for unnecessary hospitalizations. There's absolutely a need. Hospitalizations are a part of our service delivery system and in our emergency response system. It's part of the mental health continuum of care. And there's definitely a time and place for that. We also know that there's also a lot of other strategies that we can engage in that can prevent hospitalizations and the need for hospitalizations, as long as we have the commitment and integration and the engagement of families. And so the things that I'm going to share with you all today is really, a set of tools that I have found to be very, very helpful in increasing the likelihood of engagement of families. Knowing that this is a complicated process, and we're going to embark on a conversation that is often steeped in experiences and beliefs and narratives of stigma that are steeped and are embedded in cultural understanding and conceptualizations of suicide as a phenomenon, and also steeped in values around family processes and what kinds of information should be accessible, what kind of information do we acknowledge, and what kinds of information or experiences do we keep close to the family. Recognizing there's no one way to do all of this, and so I just want to be able to share some things that I have found to be really helpful. And we also have data that really that supports that our outcomes are better when caregivers are involved and supportive of any treatment plan. We've got lots of data around caregiver involvement that function to strengthen our working relationship and our capacity to be helpful in those contexts as providers. That caregivers provide really important and critical structures that help supervise and monitor and prevent the need for high levels of care that are highly restrictive when we're able to engage families fully in this process. And we also know that when caregivers are involved in this process, intervention adherence goes up, which means the likelihood of whatever intervention we're engaging it increases the probability that we'll have better outcomes. And ultimately, caregivers are often the supportive skills coach, and the people who are helping their kiddos and their youth learn how to navigate really complicated things. And so the more we are able to be engaged with families, the more we're able to have conversations about how do we do this in more effective ways, knowing that there's no book that says if you follow this, and this will absolutely work. That we have unique variables, we have unique factors, different understanding, and it creates a really strong collaborative relationship that truly honors and centers the family strengths and assets in order for us to be able to navigate a conversation around something that can be quite complicated. And so when I kind of reflect upon, what have been some of the factors that have really gotten in the way of caregiver engagement in my practice. And so some of the things I think that are the most prominent are either beliefs and stigma related to suicide. And so these may be how people conceptualize suicide as a phenomenon, or suicidal behavior as a phenomenon, what causes those behaviors, what's the intent behind experiencing this or expressing that somebody is having these thoughts, or not wanting to share it at all because it feels too vulnerable to share with other people. But I think another equally complicated experience is that many families and youth have had past negative experience with either providers or the systems. We have systems that are really set up to act very quickly without really strongly assessing the needs. And we have legal systems that are a part of this that make and drive decision-making that often will jump to conclusions or privilege the system policy over the individual need, want, or priorities in that context. And so these past negative experiences, whether with individual providers or systems or both, really set the stage for how much effort and work we actually become as providers we need to engage in order to overcome, these negative experiences of navigating systems that often are not very trauma informed and are not necessarily set up at the individual to make things feel good. I think the other pieces that are really important, part of this is that there's often just simply structural barriers that, making effective support even just inaccessible. So these are who's providing the resources in our community, who are our providers, who are they connected to, where are they located, how accessible are our providers, and also how culturally aware are our providers, and how much do providers match, their constituencies. And so these pieces are a critical part of the trust that is built around having conversations around suicide, which implies the potential engagement of a very large system that is often not very kind. And I think also the other thing that I see is that most of the families I'm working with are in survival mode. They're really trying to just survive. They have exhausted their own emotional well-being in the service of trying to provide supports, but not being able to feel successful in that, or the bandwidth or their obligations to be able to take care of a family, to financially provide for a family, or the other children that are in a family. People are in survival mode and exhausted. And it's very difficult to get to be in a space to cultivate actionable and movement forward or changes when we feel exhausted. When our bandwidth is extremely low, the smallest piece of change feels inaccessible to us. And I think another piece that also often shows up is normalization of pain, meaning that for some people, mental health is actually a luxury. That because of the systems, because of the inequities that exist, because of racism, discrimination, homophobia, transphobia, that pain and mental health services are a luxury because people are just trying to survive and navigate an inequitable and problematic system. And this becomes also sometimes an ethos that also makes it difficult for folks to accept help when offered, or even to ask for help from those same systems. And then finally, communication difficulties. And when I say communication difficulties, it is really hard to know how to express emotionally and what we are terrified about, and to express all the complex experiences we're having. If we have youth who are experiencing suicidal ideation, if and our understanding of all these concepts and our general level of mental health literacy to be able to fall down and like identify the language to use to translate what I'm experiencing at multiple levels. And so these communication difficulties as a function of that are really because it's difficult to understand and to fully understand and honor someone when it's difficult when people don't have language for this. And that is the equivalent for the providers in these contexts as well. So these are just some of the things that I have seen. These are not exhaustive or comprehensive, but these are some of the main pieces that I've seen in my practice over the last 20 years showing up that have gotten in the way of being able for caregivers to engage in this process. So I think about, I'm an educator, so I like break this stuff down to steps, but I'm also a behaviorist in general, so I also like steps. But I also want us to understand that steps are not necessarily mean a prescription. These are elements to explore. They can often flow in order and logical order, and it might make sense. And with every family I've ever worked with, it looks very different. And so our job, the art of what we are doing when we're having conversations to increase family engagement, is really, honoring the uniqueness of that conversation. But I think for us to be helpful, as if you're in a provider situation, is that we really do have to understand respect, and the conceptualizations that caregivers give to suicide. But if we're not fully understanding of how people think about suicide as a phenomenon and do this with non-judgmentalness, then it really blocks our capacity to be able to engage in an authentic conversation that is about coming together and co-creating a new understanding of suicide, if that's what we're trying to do together. And so my first step when I'm working with folks is really to really explore that, and in a gentle way, and to explore how people make sense of that. But then I also need to understand a caregiver's values, hopes, fears for their child and for their youth, I need to understand how they envision that kiddo's future. What are they hoping for them? What's really important at a values space for them to be able to transfer as part of their caregiving relationship. And then that piece helps me to center conversations around then providing some psychoeducation around suicide. This is the opportunity to engage in a conversation that's non-threatening, that is asked for permission giving, to share some information about what we do know at this point about suicide. What does science tell us? What have we learned over the last, many decades of research around suicide and suicide as a phenomenon? And this is an opportunity to kind of really get at some of those myths about suicide. Like, for instance, if you ask somebody if they're thinking about suicide, it does not actually put that in their brain, or put it on the table. This is a really common myth that most providers understand, is not true. But I think most people who have never had an experience with someone who has thought about suicide would naturally worry whether or not asking about something would put it, and make them at more risk of suicide. And that's not true. Then we have an opportunity to conduct skill building. So especially, there's how do we ask? What do we say when we ask? And be really specific about that and get practice about that. What do I say when somebody says X, Y, or Z? The skill building, of how to hold that conversation around suicide is really important. And I think most importantly across all elements of this is, how can I embed this person as a primary voice in the safety planning? And especially as it relates to means restriction, because caregivers have more influence within their family structures, but also access to whether or not there are lethal means available, and how we can engage in that conversation of restricting, sometimes temporarily restricting access to these lethal means, with the contingency that we're also working on how we have this conversation. Some of the questions that I typically have when I'm thinking about understanding caregiver conceptualizations include, how is the caregiver taught about why people die by suicide? This is a conversation I might have. What moral or spiritual or religious beliefs are related to suicide, so that I can understand that. Does caregiver, do they believe that suicide can be prevented, or is this something that's inevitable? This is an important part of understanding somebody's perspective, because it also helps to explain the strategies they're using in their home to manage these behaviors, and to provide support. What do they care about, or what do they think are appropriate and helpful practices, and what do they see as harmful? If I can center individuals' experiences based on the answers to these questions, this creates an opportunity for me to really have a good understanding of where people are coming from. When I think about also familial explanations of any problem, I really want to know, how do they define the problem? Suicidal behavior might be a behavior we might look at, but I want to understand how the family understands this. And so is that a consequence of something else? And so I want to understand where they're locating the problem, because that's also going to give me information about where people are targeting their strategies in terms of their supports for their youth. I want to know what causes the problem. What do they believe causes the problem? What keeps the problem around? And I also want to know like what is helpful, what can help fix this problem or solve this problem from their perspectives. And again, I'm doing this from a completely non-judgmental stance, and I'm doing this from a solely seeking understanding standpoint, because I've learned lots of things from all the families I've worked with, and there's lots of great insight and accuracy in their assessments. And I want to bring them into this process so that it's shared, and that I don't, as a provider or clinical social worker, own what's going to happen next, or somehow I have the expertise over their family. What I'm trying to get an understanding of is how can we work together around this problem, because I think we are all working towards the same goal, and that's for your youth to not die by suicide. I look at caregiver values, what values are most important, what values are threatened by this behavior, what does it mean for a caregiver to have a child who's thinking about suicide, where do they locate the responsibility for that, how do they fear what do they fear the most if they acknowledge suicide, what do they want most for their child's future, and how does suicide, the thinking about suicide or having a mental health condition or any other experience interfere with their hopes and dreams for their child or their kiddo or their youth. And then I want to provide education. And so these really are signs and symptoms of suicidal behavior. I want to use language I want to teach language that's asking about suicidal thoughts and impulses. I want to be able to provide them with crisis contact information and an emergency plan, and then have discussions around means restrictions. And so there's a part of this, about making sure that we understand that we can prevent suicide. And if we can open the conversation and we stay engaged and stay in that relationship and ask the questions, we can better safety plan, but we can prevent suicide at that individual level and that family level by having families engaged. And then around the skill building piece, like these are really, these are really about asking. I want to give them the language on how to ask their youth. The younger the child, the more you want to use language like, have you been thinking about killing yourself? Youth that are younger than 8 and especially 6 and younger understand that as a construct. They don't understand suicide so much as a construct. So you have to be concrete in what you're stating, but you want to be very specific and avoid language like, are you thinking about harming yourself? And there's a lot of reasons why we want to be specific, but this helps us to understand, and then we're giving them the opportunity to practice this conversation, but then also what you say in response to that. And the other piece is, staying close. A big piece of what our higher levels of care do, there's lots of pieces of intervention that are a part of that approach, but the most important piece that's being provided is support and monitoring. When I'm working with families, the ideal situation is that we can create a context that supports a system that can support that youth, but also monitor that youth so that access to lethal means are prevented, the capacity to help with skills coping, to help them cope are there, and then we can focus on safety through developing that skill set to have as a language for that family. And so this includes teaching validation, validating the valid, helping them cope, or focusing on safety. And so, really teaching, the importance of that piece. And then including them within the safety planning process. So include caregivers in safety planning from as early as we can. I generally, when I approach the engagement, I may do a lot of the suicide risk assessment with the youth individually. I want to have a really good sense, and I want to be able to demonstrate to my youth that I am listening and I'm not reactive, and I'm not going to immediately call 911 or an ambulance to come transport them to an ambulance if that's not what is needed. So I want to ensure that we've had a comprehensive assessment in a way that's private. But I also want, before I might include then caregivers into that place, into the process. And I'm going to do it a little bit differently with different folks. But once we get to safety planning, I usually bring in, family after I've already created a safety plan that's ideal for that adolescent. And I've also facilitated a conversation of how do you want your caregivers involved or included or helping, or how can they help support you follow this safety plan that you've already come up with. And then it becomes a conversation about this, how do we support that? There's other ways in which sometimes I am meeting individually with the caregiver or caregivers or family members to do some, to have those conversations, but also how do they want to be involved? What is values centered for them in terms of their capacity to help their kiddo cope? What role do they feel that they, as a parent, caregiver, or a person responsible for that youth, how do they want to be a part of that process? And it also allows us to develop some baselines around that. So it just really depends on, the family that I'm working with and what approach I might take, because I don't know that there's a one size fits all. But I do want to at least establish that I have a strong enough relationship with the caregivers and I have a strong enough relationship with the youth that they know that when we come together, I'm navigating the primary goal of everybody, and that's safety. I want to talk about restriction and safe storage of lethal means, counseling and access to lethal means as a strategy, as a training. There's lots of out there. Zero Suicide Initiative, you just Google it. You can get access to that. Missouri Institute of Mental Health in St. Louis has a huge push rollout of CALM training, but this is a competency standard that I think every person who's having conversations around safety planning really needs to be able to understand how to navigate those complicated conversations, but also tailor that conversation to the specific family needs, community, neighborhood, and factors that drive the need or the perceived needs around firearms in a home. And then I want to work with them to identify coping that can be done together. We have a lot of data, and I have a lot of anecdotal data. The more that families participate in the development of active coping together, we do this together, the stronger those skills are adopted. And you have those shared experiences. So those are my main tidbits and takeaways. So I want to give us an opportunity to open up the conversation for some questions. I know that I got here a little bit earlier than I planned to, but I guess I'm really efficient today. But I want to open up this opportunity. We got 94 people out there and probably more out there. So if we've got some questions, I would love to be able to respond.
Hi, Ryan. There is a question. I'm going to go from the bottom because I think we need to clear up a question. Mm-hmm. And that is, did you say, or did you intend to say, seeking help increases a person's suicidal attempt?
No, I did not mean to say that, and that is not what that implies. What
Okay.
it means is that individuals who start treatment or seek help for treatment are often a category of individuals that are most at risk. So when we kind of think about when do people along their trajectory of their experiences eventually reach out to professional help? It's at the end. So we as humans generally put off professional help seeking for any kind of mental health issue until it's been around for a very, very, very long time. Or we've activated our help seeking networks. We've activated our faith networks. We've activated our trusted adults and our peer relationships. We've activated the things that have typically worked for us. And it isn't until all of those which might have previously worked for us no longer works or seems to be as effective that then people seek help. And the trajectory pushes it. That means people who are seeking help are generally at a more severe level when they're entering. So that's what I mean by that. Now, I'm glad you asked that question because I don't ever want people thinking that seeking help actually increases this. This is actually a product of the inaccessibility of our systems, number one. And this is also a product of stigma about these experiences. But also, we are always trying to navigate our internal coping, our support coping first. We're activating our networks before we end up asking for somebody outside of that. And
Thank you, Ryan. So one more question for me, then I'll turn it over to Janet. You said that mental health services or obtaining mental health services is a luxury. Would you expand upon that a little more, please?
Yeah. So what I would say is I'm not saying that it is a luxury, and this is an ethos that can drive through or thread through our communities, especially when we're thinking about the inequities of our current society and who is facing what kinds of disproportionate stressors, and how has the history of racism and discrimination shown up and created inequitable systems. And so, there's a class element to this, classism element to this, and also an accessibility and a feeling of an appropriateness of mental health or happiness as mental health, which gets conceptualized that people don't have time for that. We're trying to survive. And so there can be an ethos of that.
Well, Ryan, thank you so much for the presentation. And I think it's great that you allowed a lot of time for Q&A because the chat has been hopping throughout and yes, lots of people with lots of questions. We're going to try to get to as many as possible, but Mel led us off very early with a question. As a therapist, what recommendations do you have for a therapist taking care of themselves while dealing with a suicidal client? And then sort of at the saddest extreme, if a client does die by suicide and there are those feelings of failure, inadequacy, regret, just what can you offer of how do you keep on keeping on so that you're available for the next person?
Yeah. Well, I think it's complicated, and I think it's very personal, and it's also part of community interventions that we have to think about as a profession who hold spaces of pain that include individuals who may die by suicide. And I think that, for me, and my career has really focused, I've centered interventions and individuals who have experienced a lot of suicidality and have attempted suicide a lot in their lives as a way to navigate the pain and experiences that they're having. And so for people who are kind of thinking about what role they play, this is scary. Like, providers who come into this profession want to help. And the thing we fear the most is that we make people worse, or we fear that someone may die by suicide. And we have a lot of things attached to the idea that we're responsible for that. And it's a really complicated conversation to have to say who is responsible, because there are legal elements that have to do with that responsibility. But I think that there's also the ethical and the moral responsibility that we have as providers. And so I feel that we have to name the fear that should exist. We have to name the absence of fear if that does not exist. And we need to figure out a way to cope and provide and not do this alone. And so if we have a large private practice community who aren't in established group support, as part of their support and training and professional development, doing this work alone, evidence-based and best practices is we never do suicide risk assessments alone without somebody else to be able to check our work in a way. So consultation is a critical element of being able to do this and do this competently over time. So for those that have a lot of fear in this space, we need our community to help us moderate and mediate that fear, because we also don't want to approach our suicide risk assessment, our safety planning, and our decision-making from a fear-based standpoint. The idea that better safe than sorry in this context is a better approach that really dismisses and doesn't factor into that. What is the process that someone has to go through that is their freedom in this world is being taken away from them as they are assessed and put into an inpatient unit? We're taking away somebody's freedom in this world and agency in this world to make a decision for themselves. So we don't want to do that lightly, nor do we want to do it from our affective space. So some of us are going to be more primed to the threat, to the situation to cause more fear. So we're going to need our own strategies around that. And I think that teams and people who are trusted, that we can call upon, that we can continue to learn more and more about suicide as a phenomenon, but also what to ask, how to ask, and et cetera. That helps to build our competencies so that we can feel more assured that we did this to the best of our capacities with the information we have with us, and we have a supportive network of people to be able to support us in that decision making. I've been doing this work for a very, very long time, and I have a whole team that that I check my work with. And the work is really about, this is scary, so I want to make sure I didn't miss anything. When we're afraid, we get narrowed. And that narrowedness may prevent us from being able to move into a space that provides the nuance, that provides an avenue to safety that doesn't include a hospitalization if not needed. And so when we're navigating those spaces. For some of us who do this work a lot, we actually have to be reminded that people may be more at imminent risk than we originally assessed, because we can train ourselves out of that fear because we do it a lot. And so depending on and our temperaments also, in terms of how anxious or threat attuned we are in our own histories, our own relationships to suicide or loss, can be activated in that context. And so again, we need people to help navigate that process. The only reason I have been able to stay in this very scary space that has been the most rewarding space of my life is also because I have a team that helps hold that space, because it's complicated. Because we're all human, we're all fallible. There's always the potential we'll miss something. And there are no absolute guarantees, no matter what decision we make in this context. So I could keep going on and on and on and on and on. But those are just some ideas that immediately come to mind that's been helpful for me, and maybe it can be helpful for you.
Maybe you can take a little bit of a breath, Ryan, as I pose this question. It's further up in the chat, and you can take it in a couple of ways. How has the pandemic impacted anything in data collection is the original question, but how has the pandemic impacted mental health as it relates to suicide?
Yeah. So this is a really complicated question. And I do not know definitively, and no one knows definitively. We're still learning. What I will say, the little bit that I do understand and what we have seen is that suicide rates during the pandemic did not go up. So we know that. We have data that has demonstrated child behavioral health ER visits have dramatically increased. So how has the pandemic impacted child mental health? How has it related to suicide? Is that the jury's still out exactly what that is. I think when I'm thinking about how do I think about the factors that affect, some folks that I'm working with are, for some, this and for youth, there is a lot of demands that were taken off youth life in a lot of ways. Sleep was improved a lot during that context. There was families that were more together than not together, in a lot of ways sometimes. And so I think the question is, how has it affected different people and different subsets of folks? Because I think for a lot of folks that I've worked with, or cases that I've been supervising throughout this entire pandemic, the pandemic was actually, it was actually a relief in a lot of ways, and it was a breath of fresh air to step outside of all of the demands that they felt they had to continue to meet in our society while trying to struggle and live through thinking about suicide or overcoming debilitating anxiety or depression. So in some ways, there is a relief that happened to that. Anecdotally, what I have also have seen is the longer that worked for a while, and then the opening didn't happen. And then now it continues on. And I think what happened and what was going on in the beginning of that, of now almost 2 years ago, and what is happening now are now two different questions. The legacy effect of that has worn off. Now people are more disconnected than ever. And I think from the anecdotal experiences I have with lots of school-based personnel is that all of that is being amplified now as the demands continue to increase at the school level, because there's been an entire year, a lot of not being around a bunch of other people. And so there's a lot of that social emotional learning that didn't take place. There's a lot of how do we work in groups and hang out with each other? How do we tolerate each other? And so I think that there's different impacts for different folks throughout this pandemic that, we're still learning about how these disparities are actually going to land at.
Thanks, Ryan. We have a couple audience members that I think are asking for a bit of an expansion on. You had spoken earlier about how cultural values are really important to understand where a family's coming from, their conceptualization of what actually is this problem that is causing pain to a loved one. So Alejandro was specifically interested in anything you would say about BIPOC communities. Norbert was particularly interested in Indigenous populations, but just generally, I think there's an appetite to hear more on that topic. So I put it to you broadly to expand.
Yeah, and I think that what we're talking about is, how do I understand myself in relationship to people who look different, have different histories, have different access, where my levels of privilege are. So that's one element of analysis that we're including in this context. But so from an engagement standpoint, I have to attend to these processes that are operating. I have to attend to the idea that I'm a part of a system that has systematically been problematic and harmful for many BIPOC folks. And I also think about, how do I translate this to understanding, and is centering the person's experience and understanding. And when I say cultural values or cultural conceptualizations, what I'm understanding is, how did you learn about these topics? Who taught you that? How far back does this go? Who are we connected? How collective are we in that understanding of these concepts and phenomenon? And who are the people that are most equipped to be helpful with this with suicide? And the more I can understand and who's acceptable, because then I can also understand how I relate to all of that. If I'm not falling into any of these categories, as me as a provider, or as you as provider, and then it's also trying to figure out, okay, then what role can I play? Knowing that acceptance of help from me may not be an appropriate experience for someone, or extensions of trust, I have to earn for really important reasons. And so I think when I start thinking about suicide, families, and engagement, I think the questions at the macro and more kind of system and community level are also a little bit different than what we're talking about when we interact with folks within a system, and who are showing up. And so, I mean, it's a complicated piece. It's a dance. It's an understanding of, how do I understand myself in context, and how do I understand my own histories, and my own biases that may show up in this space, and how do I provide an equitable way of sharing this information so we can create a new understanding for folks that's shared.
There are so many interesting questions in the chat. Here's one. Have you seen a correlation with normalizing suicide as an out with abuse of cannabis for the youth?
I have not seen those. I mean, we have a lot of data about substance use and increasing the probability of acting on suicide attempts. A part of that is it lowers inhibition, but I haven't seen something specifically around that. That doesn't mean that it's not. I'm not an expert in all areas of suicide.
Thank you. Can you speak to about Indigenous people? Are there different contexts for helping?
Yeah, I'm not Indigenous. I don't have Indigenous heritage. And I think when we're thinking about engagement and the role of suicide for different populations, I think we have to understand in our work that suicide may mean something very different. And given the historical connections of colonialism and historical connections around Indigenous healing practices, what we have found, or what I've seen to be extremely helpful, is that that these are elder-led initiatives, that these are not necessarily driven by professionals, and that communities are coming together to have conversations, to engage in skill building that is already culturally centered and already being taught. And I think that, when we think about and who we're working with, we have to recognize that suicide functions differently for different folks and different people. And a part of our assessment is also understand, what does suicide bring somebody towards? And spiritual beliefs and historical and connectedness pieces around that, may mean that my relationship to suicide is actually getting me closer to the elders I miss, or people that I miss. And I'm not saying that that's the case in every single person who thinks about suicide who is Indigenous. I think we have to be open to the idea that suicide functions and looks different for different people based on their own histories, cultural conceptualizations, but also their place within societies that are disproportionately leading to more and more constraints and prohibitive around agency. And again, I'm not an expert in Indigenous healing practices.
Thanks for that, Ryan. So Bailey, I believe, is a CASA volunteer. I didn't write that note, but I did write Bailey's question. And Bailey is not a therapist, but works with kids that they're concerned about. It tries to engage with families, and would like for you to speak a little bit for those that don't have therapy training.
Yeah.
What might engaging with a family look like that doesn't, cross any ethical line of what you should and shouldn't do, but express a concern or generally advocate as a layperson for a kiddo?
Yeah. I mean, I see such a critical role for peers in this space, for parents of youth who are experiencing suicidality to support other parents in these spaces. And I think fundamentally what we're talking about is, gatekeeper training for those who are having those conversations. Gatekeeper trainings are a public health intervention that teaches somebody to be able to recognize signs and symptoms, gives you language to have the conversation, and that the role is to link to a resource, so for assessment. So the idea would be me as a clinical social worker, and if we were working in tandem, that you would be given and equipped with some knowledge around suicide, how to engage in this conversation with anyone, either have a conversation with parents about worries about your kid, their child, or their youth, based on these signs and symptoms, and then link to a resource that can be helpful. And so a part of this is, we want to make sure that you're equipped with knowledge of signs and symptoms, how to have the conversation, and a set of resources, so that when you enter into a conversation with someone, you have accessible to you the resources and the knowledge and the skills to be able to hold that conversation. Knowing that no one's assessing suicide, unless you are clinically trained to do that and hold a degree and a licensing that allows you to do that. Essentially, that's you participate in that screening process because you're noticing something, but you're referring them to the people that have more extensive, training to kind of make decisions. I don't know if that answered.
I think it absolutely did. You framed the goal and the role, and what anybody who cares about a young person can and should be doing if you see something that's troubling. So we are down to time for a very last question. I'm going to let it be from Latrice, who I believe was a student of yours.
Oh, Latrice.
Yeah, and so Latrice is, I think, hearing you talk about having a community of people that you're able to talk to as you process, did I miss something? What's an appropriate step? What ideas do people have? And then just also kind of ongoing skill building, because managing folks with suicidal ideation is not social work 101. It's some of the hardest stuff we do. So what would you suggest to somebody earlier in their career, earlier in their experience, to continue to build skills to be ever more competent in this space?
Yeah. One, Latrice, you should reach out to me, because this gave me a really, really good idea to think about on how we can create a system within our community to be able to support that. I think what we're talking about is fundamentally, even us as trained mental health professionals who are supposed to have this level of training and expertise, don't actually have this. Less than 20% of schools that train mental health professionals have formal curriculum in suicide risk assessment, intervention, and management. And it's all the way up into our medical professions. So there's a part of what you're speaking to is that we have a competency deficit that needs to be addressed first. But I think the second piece to this is finding those trusted people that you have learned from, reaching out and maybe thinking about, can we form like an agreed upon collective to help support each other in the work that we're doing? If you are embedded in a system or an organization, then it's advocating in that system for systems of support that will have, that people can access, but also policies that support providers in this process that isn't solely just the transaction and teaching you, like the policy is you do X, Y, and Z, but that there is a built-in consultative element to the policies. And that's, you know, that is a tangible advocacy and policy shift that you can work towards within an organization. Outside organizational processes, it's really finding those trusted folks, you know, in your area that can serve and create an agreement around that on how to do that. So that's kind of what I came up with. And
You come up with a lot. You do a great job. Ryan, we could keep going with this audience for a very long time, but we're actually slightly over the hour already. I want to give you an opportunity to provide any closing thought, reminder, take-home message that you want to leave us with.
yeah, what I would say is that we have every capacity to prevent suicide in our communities. And youth suicide is devastating. And we have tons of hope. So the more we can come together collectively at the policy level, the funding level, the organizational, the training level, and throughout our industries, we can address this issue in our communities. But simultaneously is that I know that there are complicated experiences that make it difficult sometimes to engage families. And we have to keep trying. That if I'm speaking for the mental health profession, we have to keep stepping up and reaching out and learning about how to engage and navigate complicated historical and current issues and experiences that make it not likely that people would want to engage with you as part of a profession. And so I'm here, I do this work. I have some really interesting ideas that I've already generated that I'm going to be coming back to Janet about, and also thinking about how we support providers, you know, in the community to have these conversations and to keep learning. And I appreciate everybody for your last hour.
Ryan, thank you so much. Audience, please join me in thanking Ryan for sharing his thoughts and his time with us. Cynthia, thank you so much for just the most skilled co-moderator I could hope for. Audience, wonderful questions, fantastic engagement. I'm sorry we didn't get a chance to answer all of them, but I'm hearing from Ryan that he's got some ideas of what he's going to bring back to us. So please do stay tuned for that. And with that, we're at time. I wish everyone a very wonderful rest of your day. Please stay healthy and safe out there, and we hope to see you at another program very soon. Take care now.
Bye.
Bye, everyone.